when I talk to clinicians and do supervision, there are just a few terms that I'm beginning to use a lot more, and these are terms that I call pseudo-psychiatry, where somebody reads an article and whether it's in a lay press or in an academic press, and there's a nutrient that was found to be helpful for schizophrenia or St. John's wort for depression. And people begin to start using these nutrients without really understanding underlying causes of illness. Rarely does it help, and it in many ways turns patients off from looking at integrative psychiatry. Label therapy is a term that I use, which is just very rampant both in the integrative medicine community and in traditional nutritional community. We read an article that a certain nutrient might be helpful in the treatment of depression. Let's take something like SAMI, is often cited. And the supplement manufacturers puts a dose of SAMI, 100 milligrams or 200 milligrams, and people go out and buy SAMI, and they say it doesn't help. Well, the literature clearly stated that 1,600 milligrams of SAMI was effective for the treatment of depression or an augmentation strategy. But our colleagues, our patients, uneducated consumers are just buying nutritional products because the label says SAMI. We see it with all nutrients. And then the anti-psychiatry movement is pervasive, and I just need to urge everybody to not get on that bandwagon, even though the focus of my work, and I believe many of you, is looking at nutritional blog that I saw, John Rappaport, I believe he is a very experienced science writer, and this blog was titled "Mental Illness Doesn't Exist." This was a couple weeks ago, and basically he's sharing with his readers that of all the psychiatric diagnoses listed, there's no blood test, no urine test, no saliva test of any kind. So he said, how could these illnesses exist? He goes on to say that these labels are meaningless. They might provide some relief for families or parents, but it doesn't mean that there's anything wrong with the patient, and it can actually be a diversion from knowledge that would actually help the child. And although this core premise is something that I talk about all the time, the over diagnosis and reliance on the DSM as a symptom-based psychiatric model does not help our patients. I believe this, toxic anti-psychiatry movement, which John Rappaport is intellectually providing a framework by saying mental illness doesn't exist, is just as tragic. Because I believe many of you have sat in the room with patients who have been psychotic, who've had significant incapacitating OCD, depression, tics, autism, and nobody can tell me that these patients aren't suffering from an illness. But the goal of what I call integrative psychiatry, the core work that we do looking at these biochemical tests, is really trying to understand, is there some biological cause? This is a slide that I use a lot, many of you have seen, and a real simple roadmap. This was based on some of the early work by Sidney Baker, a pediatrician in the autistic community, where he simplifies the process that a history and an exam is critical, but it is not the core essence of how we go about helping a patient. We ask two questions. Is there something the patient needs? Is there some deficiency state? Or is there some toxic environmental and or allergen that the patient needs to avoid? The simplest example that I just wanted to share with you today about is vitamin B3. As in 2012, 2 weeks ago, I admitted a patient to our eating disorder unit with what we used to call pellagra. So I use this as an example of a nutritional deficiency that has profound mental health repercussions. For many of you, you've understood this. Pellagra is a vitamin deficiency that was rampant in this country in the early 1900s. The earliest manifestations were anxiety, depression, fatigue. This was primarily in the poor South, where corn or cornmeal was the staple in the diet. As this disease progresses, as the lack of B3 progresses, individuals resemble those of major psychotic illness with delusions and hallucinations. 1/4 to 1/2 of all psychiatric hospitals in the South in the early 1900s were filled with patients that were diagnosed as schizophrenia but were found out to have niacin deficiency or pellagra. Many of these patients got better. They left the psychiatric facilities, and they were given very tiny amounts. The work of Abraham Hoffer, orthomolecular medicine, really outlines how high-dose vitamin B3 can be helpful for the treatment of schizophrenia. This is a simple treatment. There are 19 countries around the world with orthomolecular medicine organizations looking at the use of B3 in the treatment of psychotic illness. And I use this as a first example because, again, last week working in an eating disorder facility, I admitted a 50-year-old woman to the hospital who's been a vegetarian her whole life, who suffered from obsessive-compulsive disorder and an eating disorder. And she presented actually to Mass General Hospital about a month ago, disoriented, delusional, appearing psychotic, with classic skin rashes consistent with malnutrition and pellagra, as well as the diarrhea and psychotic processes. She was started, luckily, on high-dose nutritional therapy and vitamin B3, and she was transferred to our unit for ongoing eating disorder therapy. Pellagra continues to exist, particularly in those that are restricting their diets. More importantly, the point here is a simple nutritional deficiency can create a major psychiatric illness. So when we go back to the blog of Mr. Rappaport saying mental illness doesn't exist, we continue try to help. This anti-psychiatry movement says that clearly mental illness exists, but our traditional reliance on psychopharmacology never gets at the underlying cause. When we talk about psychosis, one of the concerns about the medications that we use to treat psychosis is a very serious chronic side effect called tardive dyskinesia. It is a disorder resulting in the involuntary repetitive body movements, primarily from neuroleptics, antipsychotic medications, and at times from other medications that affect dopamine metabolism in the brain. The reason why I bring this up, one, is that I have a fascinating case to share with you, but two, these antipsychotic medications are now approved for the treatment of depression. So Abilify, Seroquel are being marketed from TV ads, as well as pushed to physicians through pharmaceutical companies for the treatment of depression, which means the use is skyrocketing and the risk for tardive dyskinesia is tremendous. I had a patient walk into my office approximately 6 months ago. She presented She's a 50-year-old woman. She presented in early February with a serious tardive dyskinesia. She currently was not on a neuroleptic, but she developed the tardive dyskinesia after being on numerous psychotropic medications, and these included lithium, trileptal, Depakote. She's had Abilify and Geodon in the past. She was a high-functioning professional working actually in a hospital, but the tardive dyskinesia became so incapacitating that she was not able to work. She had lip smacking that you see on the street sometimes with homeless schizophrenics. She had involuntary facial movements, hand movements, and was profoundly incapacitated. The literature for tardive dyskinesia, there's some research looking at vitamin E, and there's some research looking at the fatty acids. This 50-year-old woman was placed on a nutritional program of branched chain amino acids, vitamin B6, magnesium, and fish oil. When I first saw her, because there's literature to support that. And then we looked closer. We did the fatty acid testing, we did the organic acid testing, and we did trace mineral testing. We found that she was profoundly deficient in selenium, and we found that she was deficient, as was expected, in the branched chain amino acids, so the isoleucine, leucine, and valine. And I saw this woman back in my office this week. There was improvement after the first few months, but when I saw her back in the office this week, the tardive dyskinesia had completely resolved. Again, she was very compliant with her nutritional program, which was extensive, but the permanent side effect of tardive dyskinesia, where I have only seen modest improvement up to date, was completely resolved. Extremely gratifying work to help somebody who had struggled so much. This is really an important study that I'm just completing a blog on and wanted to share with you here today. The Journal of Neurology. It was written a number of months ago, but basically the summary here is that laboratory testing is critical to understanding mental health and mental illness. So there was 104 non-demented adults, 85 and over. They looked at 20 nutritional biomarkers, and they did an MRI and many nutritional and cognitive tests on these patients. They found that those with elevated levels of B vitamins, C, D, E, the omega-3 fatty acid, correlated with improved cognitive function and also showed increased brain size. Their diet had no bearing on these nutritional biomarkers. And it's one of my pet peeves, one of the mantras that I'm trying to get every clinician to understand, that we can't always understand nutritional vulnerabilities, nutritional deficiencies based on our dietary histories. We have to test. We have to do our objective laboratory tests to understand what's going on, and our treatment is based on these objective findings. And as many of you are aware of, there is very few objective tests that traditional mental health clinicians look at. Again, Journal of Neurology this year, they were able to show that the biomarkers in the blood were relevant to cognitive function and brain size as these non-demented adults aged. The kinds of tests that we do routinely on patients walking into the office are on the screen in front of you. It's very hard for me to explain why someone might be depressed when I know there are 10 or 15 different reasons that could contribute to fatigue and depressed mood, from hormonal deficiencies to heavy metal toxicities to vitamin and mineral kinds of deficiencies. And again, I'm going to repeat a lot tonight. How do you know if you don't look? How do you know if you don't test? The work that I do is what I call integrative psychiatry. Medications are not the enemy, but if we can find the underlying cause, we can find a cure. This is a patient that I'd seen a number of years ago. Some of you have seen this slide, but it's a good example of simple biomedical testing that has profound implications. It was a very successful entrepreneur, 36-year-old female with depression and anxiety that became increasingly incapacitating with insomnia. She presented to her primary care doctor, who did a physical examination. Her doctor actually at least looked at thyroid tests, iron, anemia, everything was normal. So Marcia was told there's nothing wrong. But as many of you understand, Marcia still felt terrible. The next visit to the PCP, she was prescribed Lexapro, the antidepressant, and I believe at the time this medicine was prescribed because it was still being given to physicians for samples. So she was given Lexapro, little relief, and then Ativan was added because she wasn't sleeping, and Abilify was added to, quote, augment the effect of the antidepressant. This is what our consumers and our patients are being bombarded with in primetime commercials. Eventually she got to a psychiatrist. Just before I saw her, Wellbutrin was added, another antidepressant that works differently than the Lexapro, and then Lamictal was added a few months later because she was irritable and they thought maybe she has an underlying bipolar disorder. This is a scenario that I see every day, literally every day in my practice. Multiple psychotropic medications that keep being added. The world that we live in, we don't have time in a psychopharm model with 15-minute med checks to actually stop a medicine, so we just add a second medication and a third and a fourth. The average numbers of psychotropic medicines have increased dramatically from an average of 2 to now an average to over 3. So Marcia came into the office. We did our routine blood screening, which is looking at B12, vitamin D, iron, numerous tests that are traditionally covered by insurance, and those were all normal. And we did our amino acid screen. And if you notice here, all the essential amino acids were low. And even most of the non-essential amino acids were low. Now, the interesting thing about Marcia is that Marcia was a very healthy individual. She ate what we call the perfect diet. The bottom screen is supposed to be her brown rice, avocado, and salmon flown in from Alaska. That was wild. So again, she was very concerned with her health. She did yoga and she ate extremely well. But when we get a blood test, fasting amino acid test where all the essential amino acids are low, and here essentially all the amino acids tested were low, there's some disconnect with that healthy meal that Marcia was trying to eat. And that disconnect has to do with digestion and absorption. So the recommendation for Marcia was very simple. We gave her an amino acid powder of all the essential amino acids that she mixed with a juice. It was not a protein powder because breaking down a whey protein powder takes enzymes and work, and she did not have adequate digestion. So we gave her just the pure free-form amino acids, and then we gave her the digestive enzymes with hydrochloric acid. Many, particularly consumers, they're taking digestive enzymes, they're going to the health food store, They're going to CVS, getting digestive enzymes. There might be some pancreatic enzymes, some lipases and proteases, but there are no, it does not have hydrochloric acid, and you need fairly hefty doses of HCl to begin the process of breaking down protein and helping with the cascade of digestion that is needed. This woman felt back to herself after 4 weeks of a simple nutritional intervention. This wouldn't have been picked up without this low amino acid. A dietitian wouldn't have understood this because she ate the perfect diet. There are many other reasons why someone's amino acids would be low, and I guess I just need to share with you that the amino acid testing is one of the most important parts of my practice, particularly fatigue and depression. Low protein intake, many vegetarians aren't getting adequate protein, so their amino acids are obviously going to be low. We talked about Marcia, where she had inadequate hydrochloric acid. And then one of the more common things that we're seeing, particularly in the elderly, is the epidemic use of antacids, which slowly get in the way of our acid production, which eventually impairs our ability to break down protein to make the amino acids required for neurotransmitter synthesis. Some of the cases that I have seen recently in my practice are 3 here. Maria is a woman who was on disability for her depression. She had to leave a professional job due to chronic debilitating depression with psychotic features. Tried on multiple medications, and each medicine had numerous side effects. She came to see us, and again, lots of the screening lab works were completely fine. She was taking lots of supplements. Her fatty acids were normal. Her vitamin D was normal. But as Marcia, she had profoundly low levels of all essential amino acids. Her mood started improving. Her energy improved with amino acid supplementation. Again, her diagnosis coming to me was bipolar illness. Sandy was a young adult, vegetarian, who struggled with an eating disorder when she was younger. Eating disorder had resolved, but the fatigue and depression kept getting worse and worse. The major finding for Sandy, again, was these low levels of amino acids. Harry was an older gentleman who never had a history of depression, but in his early 50s developed debilitating fatigue and depression, diagnosed with sleep apnea, which helped his mood a little bit, but not significantly, came to see us. And again, the most significant test was low levels of amino acids with complete resolution of the fatigue and depression with amino acid supplementation. I certainly believe the CPAP and the treatment of sleep apnea helped, but he had been on this CPAP for over a month without significant improvement. I could go on, but these are just a few cases of looking at fasting amino acid testing for the treatment of depression, fatigue, and for some individuals, bipolar depression. That's all the alternative medicine your HMO will pay for. Oftentimes patients can't afford the testing if their insurance doesn't cover it. If you know by dietary history they're not getting adequate protein, or you suspect that digestion is not appropriate, then it's easy enough to give hydrochloric acid and digestive enzymes with the amino acid powder to patients with fatigue and depression. You're going to hear a lot about cholesterol levels at the Santa Fe seminar. I just wanted to share with you some of the cases that I've seen over the past year where low cholesterol and in my book, low cholesterol would be under 150. That's where most of the research is. Has had profound effects on mental health. And these are only some of the cases that I've seen in the past 6 months. A 34-year-old female with eating disorder with a cholesterol of 110. Now this is significant for any of you who treat eating disorder patients, because the majority of patients with even anorexia who have not had fat for many years have high cholesterol levels. Typically, whether it's stress or the chronic state of malnutrition trying to repair itself, cholesterol levels are routinely elevated in patients with eating disorder. When we have a patient with a very low cholesterol, they tend to be those most treatment refractory and often those most impulsive and aggressive with frequent suicide attempts. This patient was chronically suicidal, chronically depressed, and multiple admissions to the hospital where we really couldn't help her, and she was referred to actually ECT, and because her level of depression was so profound. Next one is a 16-year-old male with aggression, ADHD, and a mood disorder. It's not listed. Had a total cholesterol of 90. This gentleman was out of state. I have the chart in front of me. I just want to share with you his progression. We used cholesterol supplements. We were able to slowly increase his cholesterol. For those of you that use cholesterol, and you understand that it takes some time to replete cholesterol, and often is a slow process. But what I've found in all these cases where we were able to supplement with cholesterol, that as the cholesterol level gets elevated, the patients improve. This gentleman got up to 114 within a few months, and then we were able to get his cholesterol up to 130. Significant improvement in aggression primarily. The other interesting finding I have seen with low cholesterol is a tendency to marijuana abuse. These individuals tend to crave marijuana and feel better on marijuana. This is a 22-year-old bipolar OCD, chronic marijuana use, who came in with a cholesterol of 112. Again, unable to attend school, as we were able to help him, one, get off marijuana, increase his cholesterol. He was able to complete grad school, and his cholesterol got up to 140. Another 20-year-old college student, again depressed, marijuana abuse, cholesterol of 105. I had been treating his father for depression. This boy has been in college for 3 years, pretty much sitting in his room playing video games, thinking about ways to kill himself, and had nothing ostensibly. He had a good home, very bright, and lots of other things going for him. He's in the beginning of treatment. We were able to help change his diet. His cholesterol has increased a little bit to 112, and his mood is slowly getting better as well. The next patient is a 60-year-old with OCD, and eating disorder, and marijuana. Again, the marijuana abuse was striking. This gentleman we saw starting last year. As we treated his eating disorder, he became better able to eat sources of cholesterol, including eggs. He was on the cholesterol supplements. As his cholesterol increased, the most dramatic effect, completely off marijuana. And the last patient is a 14-year-old girl with PDD, OCD, and eating disorder, and a very dramatic trend. Her eating disorder completely disappeared, her OCD markedly better as her cholesterol increased into the 140s. This was one of the simplest patients we were able to increase cholesterol. So Just some of the cases that we work with, and I want to give you kind of the breadth of what a low cholesterol patient might look at. There's clear depression, often aggression, and we are seeing now this consistent craving marijuana and feeling better on smoking pot. B12, really one of the most common nutritional deficiencies that we see. It is one of the most dramatic kinds of treatments that we do because patients feel better quickly, and we've made major changes in what we would call major mental illness. The symptoms of B12 deficiency, like many of the nutrients you're going to hear about, vary from individual to individual. There is everything from hallucinations to simple apathy and irritability. There are also physical manifestations that can be confused with everything from MS to Parkinson's disease. In my practice, I aggressively treat everyone with a B12 level under 500. This is picograms per ml. Many individuals have levels of 200, 300. The primary care doctors say they're completely normal, not to treat it. I put this slide in to show you, this is from Quest Laboratory, and they were able to add this little disclaimer at the end saying that there's 5 or 10% of patients with a levels between 2 and 400 that may have neuropsychiatric symptoms. These are only been added in the past year to Quest Laboratories. The literature, these are just some of the case studies. I'm going to go through these quickly so I can talk about some of the cases we've seen. The literature is so dramatic because if you see individual cases of psychotic depression, severe depression, here's postpartum psychosis, suicidality, and even mania written up in psychiatric journals associated with B12 deficiency. The most common that we're seeing in our practice is fatigue, panic disorder, anxiety, depression, and a number of the last few cases we've seen was actually a psychotic depression. So some of the cases I've seen in the past few months, Ben was one individual who was a college student who had been increasingly depressed, unable to complete the semester. When we saw him, he was delusional, he was paranoid, and the only deficiency was profound B12 deficiency, and with intramuscular injections, the psychotic depression resolved. The other male here, another male, Mark, was an Iraq vet who came back with chronic anxiety and fatigue. He was extremely health conscious, trying every diet he could, going to the gym. He had horrible experiences with medication. He again was giving IM B12 due to a B12 level under 300, which his PCP told him it was completely normal. And within a month, completely different, said the best he's ever felt in his life, was able to start a business, and was very upset at me when I said he doesn't need any more B12 shots as his levels were adequate. Sarah is a patient with OCD and anxiety. The OCD is quite subtle. It's this chronic ruminating pattern. She does not have any compulsive behaviors, but just always worrying and always anxious. B12 was the major nutritional intervention. She was also vitamin D deficient, although we rarely find vitamin D associated with this kind of anxiety. And again, intramuscular B12. I currently use 1,000 micrograms 3 times a week for about a month, so 12 shots a month for Sarah. Emily is another case that I have here. She presented with just a profound depression. She was in college, stopped a number of years ago due to the depression, difficulty living at home with her parents, on multiple psychotropic medications. We treated her with IMB12 without changing any of the medicines, with significant improvement in mood. Again, a very simple intervention. My clinical advice is treating patients under 500. The sublingual or liquid B12 of methylcobalamin can be very helpful. I tend to use, for any level under 400, the intramuscular methylcobalamin injections. Lithium, in particular lithium orotate at this point. This is a woman that I saw a couple of years ago, and it's an interesting history. She was 60 years old, and she struggled with bipolar illness for 30 years. She had a profound family history of bipolar illness with multiple individuals, grandmother, cousin, father, aunt, who had bipolar illness, with one suicide and multiple suicide attempts. She was placed on lithium carbonate and did extremely well. She worked for 25 years in a major city with improvement in mood. Whenever she tried to stop the lithium, she became depressed. But after 25 years, she developed renal difficulties, and her nephrologist required that she stop lithium. So she was essentially homebound off of lithium for 5 years before I saw her. She had a suicide attempt 2 years after being taken off lithium. She overdosed on medications. Her marriage was completely dysfunctional. I saw her when she was on Depakote, Abilify, Zoloft, Synthroid, without any significant relief from the depression. Her routine screening test showed marginally low zinc, B12, vitamin D, and if you see anybody who's knowledgeable about kidney function, the creatinine of 1.74, that should be under 1, demonstrate impaired kidney function secondary to the lithium. Well, this patient was repleted with B12, vitamin D, and zinc, with modest improvement, but unable to significantly relieve her depression until we added lithium orotate. She took between 10 and 15 milligrams of lithium orotate with the other nutrients listed above, and over the course of 3 months, a profound improvement in her mood. She was followed for a number of years in the office. If you can see that her lithium level throughout this was always under 0.3, essentially non-detectable, on 10 to 15 milligrams of lithium orotate. Her creatinine level pretty much stayed the same, 1.77. It went up slightly, but then down to 1.79. So the lithium orotate did not affect kidney function. She saw her nephrologist, who demanded that she get off the lithium. I never called, didn't know anything about lithium orotate, but she stopped the lithium in August 2010. At that time, she became manic. She did not sleep. And she, on her own, without contacting me or the nephrologist, started retaking lithium orotate. She was able to taper herself to the lowest effective dose, which she found was 5 milligrams every 4 days. So she didn't need 10 or 15 milligrams every day. But if she went below this 5 milligrams, she became manic. And so she continues this day on lithium orotate, 5 milligrams every 4 days, and continues to do well. She's working, and very energetic, not depressed. Lithium is an incredible nutrient. It has been used for many years. In 1949, it was first understood as a medication that might treat the mania, although we used it more simply to help hangovers. In the early 1900s, lithium was added to sodas. There were lithium sodas, and 7-Up had lithium up until 1950. Very, very commonly used to help with hangovers. Lithium has profound effects in the psychiatric literature. These are some of the side effects, where dramatic decreases in suicidal ideation. This was a very famous study on lithium. The rates of suicides decreased almost 7-fold. When these bipolar patients stopped lithium, it increased 14 times. The first year off lithium, the suicide rate rose 20-fold. Dramatic, dramatic changes. And here's just one study, or 3 studies, looking at just lithium in the drinking water. Micrograms of lithium in the water associated with suicide rates. The higher lithium, the less suicide rates. How does lithium work? Low-dose lithium, we're not sure, but there's increasing information showing that it helps with brain inflammation. We'll be talking a lot about in Santa Fe, but lithium works by helping DHA, one of the omega-3 fatty acids, turn into a chemical that has significant anti-inflammatory effects in the brain, and it's a lithium-dependent reaction. There's research done at Johns Hopkins, where they found that lithium essentially returns the amygdala to normal. These are MRIs on bipolar patients where the dramatically increased blood flow in the amygdala, and on lithium, functionally the amygdala returns to normal blood flow patterns. So lithium is a big part of my practice. These are some of the cases I've seen over the past probably 4 months, not longer. Bipolar 2, a 45-year-old woman who was actually in the medical profession. She was irritable, depressed, struggling in her relationship, struggling at work, tried many medications, primarily the antidepressants, had horrible reactions to mood stabilizers, and this patient on lithium orotate had profound effects in her behavior and her thought process. She didn't realize some of the irritability and mood instability that she had with her family until she started feeling dramatically better, and her husband and kids pointing out to her. This woman broke down in tears in my office as she started feeling so bad for how she had behaved over many years in her marriage and with her children. Again, the intervention was lithium orotate, 10 milligrams per day. Road rage. I had a gentleman in his late 40s who, one, made me nervous as I was about 15 minutes late and came in quite hostile, angry, and threatening in my office, and how because I was late. So little concern there, and as I took the history, obviously anger one of his issues, that the road rage was so profound that he was worried that he would hurt somebody. He had been on antidepressants. I didn't change any medications, but I saw him within 4 weeks of just adding lithium orotate with a very significant improvement in these aggressive outbursts on the road to strangers. Irritability and family history of substance abuse could go together, because the next few patients really are individuals that have a family history of substance abuse. They are not diagnosed with a mental illness, but irritability is a very, very common symptom, and I have many, many patients where lithium orotate is the sole intervention for these individuals. And then the bipolar 1, the patient we just talked about, as well as a number of other patients. A woman I recently saw in follow-up who had been hospitalized a number of times for mania, some of it induced by using St. John's wort or SAMI. She was a health food fanatic and indiscriminately took these medications. But what we were able to do, because she was so petrified of medication, able to keep her out of the hospital. I've seen her about 6 years now with lithium orotate. So again, like B12, we have variations in this mood, bipolar, substance abuse diagnostic categories. There's not one clinical presentation where lithium I see. I started my vegetarianism for health reasons, and then it became a moral choice. Now it's just to annoy people. One of the concerns that I had in my treatment of anorexia while we wrote this book is the very, very concerning nutritional deficiencies of zinc and B12 in patients with anorexia, particularly adolescents. And essentially some of the themes in this book is vegetarians beware, particularly for prepubescent adolescents that are restricting meat, because it's very hard to get adequate zinc. The physical symptoms of anorexia are identical to the physical symptoms of zinc deficiency. We get zinc primarily from animal products. A lot of dairy, a lot of grain products inhibit zinc absorption. One of the things, and I'm going to go through these slides quickly, but if you notice the physical symptoms, attentional difficulties, depression, insomnia, that zinc is required to make melatonin. Zinc is required for proper serotonin function. So hence a lot of eating disorder patients struggle from depression. But I want to share with you, I'm going to skip some of these slides. These are individuals that I've seen the past few months with zinc deficiency and significant mental health problems. Amy was interested because she also was very concerned about her health. She went to the gym. She did mind-body medicine. She was yoga, training to be a teacher. A yoga teacher. She ate well, didn't drink or take coffee. She was doing everything right. I have her chart in front of me. She presented with a serum zinc level of 55, which is quite low, and she was not a vegetarian, that she did eat healthy meats and fish. With subsequent treatment of the zinc, again, it wasn't the only nutrient, but it was the prime nutrient. Initially, I used 90 milligrams a day and cut down within a month to 60 milligrams per day. That she noticed a significant improvement in her mood and was better able to tolerate increasing her diet. Bill was a 50-year-old gentleman with not only depression, but he was obese. He ate meat and was shown to have both a serum zinc level as well as a red blood cell zinc level that was low. And again, zinc was a core nutrient to help him with depression. Obesity and binge eating is a common combination where we see zinc deficiency. These patients are eating a meat and should have adequate sources of zinc. It's unclear what might be contributing to the zinc deficiency that we're seeing. This can be tested for by looking at red blood cell zinc, looking at hair levels of zinc, or looking at a 24-hour urinary excretion. This the child underneath it was a 16-year-old with anorexia, and I put in some of these functional markers of zinc deficiency that's a common part of the work that we do. So looking at the alkaline phosphatase, which is a zinc-dependent enzyme, and the white blood cell count, both are decreased in zinc deficiency. Particularly in adolescents who are still growing, their alkaline phosphatase is usually 100 times more than normal, because alk phosphatase is utilized in bone growth. So we see zinc deficiency in our eating disorder patients, but we're also seeing zinc deficiency in our overweight patients who have depression. This is a slide many of you have seen, a woman that we've admitted to our hospital, 12-year history of eating disorder, who started eating flour when she was 16, and she liked the taste of it and was eating between 2 and 4 pounds of flour a day. Why was she eating flour? Well, if we look at her neuropeptide test, she had extremely elevated levels of gliadorphin, which is a urinary peptide from the breakdown of gluten. This patient tragically did not follow through on a gluten-free diet and really struggled for years with OCD and anxiety. This is also, with the amino acid test, a test that we do on everybody in the office. It is early on typically associated with autism and schizophrenia. In about 1995, I did this test on a 7-year-old girl with very, very serious OCD. It was almost by accident. We were looking at an organic acid, and I had checked this test, and very, very high levels of casomorphine. And since 1995, I've been doing this test on all my pediatric OCD cases, and I believe over 50% have come back positive. I saw a girl this morning who is a 4-year-old with a strong family history of OCD that's beginning to have profound impairment due to her OCD. We haven't done this test yet, but it's pending, but I believe that dairy is going to be a problem. So urinary peptide tests, again, when these bloggers or anti-psychiatry people say we don't have objective tests in mental health, well, I believe urinary peptides is one of the many objective tests that we have that is not commonly in the general public elevated, but when it is, it typically reflects both this impairment in digestion, but they're usually mental health repercussions, be it anxiety, fatigue, or depression. These are some of the cases that I've had over the past couple of years with elevated levels of primarily casomorphin. The coffee mate is a story about a woman who had done pretty well getting off casein, but not as good as I had expected because she was very compliant. But then she told me that she drinks coffee mate all day long in her coffee, and essentially she drinks the coffee to get the coffee mate. She was addicted to the coffee mate, many, many scoops, and apparently coffee mate is very high casein. Another patient, the whey protein, he was a bodybuilder and well, actually just started bodybuilding in college, was bulking up on very, very high doses of whey powder, and the cheaper brands actually add casein as fillers. So most of it is casein, and he was able to take this powder 3 times a day. His OCD increased dramatically to the point where he wanted to kill his parents. He had these intrusive thoughts, wanted to kill his parents, and required hospitalization in a psychiatric facility. I used the granola bar because many of these cheap granola bars have casein, and a patient didn't get better until she was able to eliminate all sources of casein. I use the cheese because many patients tell me they're dairy-free, but they live on cheese for breakfast, lunch, and dinner. And this woman who had to have her bowl of ice cream every night to get to sleep, very high levels of casomorphin, and she used the neuropeptide from the ice cream to help her sleep. Other kinds of nutritional deficiencies that we see all the time result from celiac disease. Again, the theme of all of my work is what nutritional deficiencies are present in an individual, and when we can, we try to find out what may be the cause. Celiac disease patients do not always have GI symptoms. They often present with mental health symptoms. They are deficient in the essential fatty acids, the B vitamins, some of the amino acids like tryptophan, all the essential nutrients for brain function. And it's not uncommon that patients with celiac disease are twice as likely to suffer from depression as age-matched controls. A quick case is a college student who came to see me because he was on very, very high doses of amphetamines that his parents were concerned about when he came back from college. And he was on high dose of benzodiazepines, Xanax, Ativan, because he was so stimulated from the stimulants. He developed the ADD, quote, ADD in college because he wasn't able to pay attention. He was a straight A student in high school, not a typical ADD pattern. And what we found when we did the blood test that he was deficient in iron, B12, and many, many other nutrients, eating a healthy meat diet. So looking more closely at malabsorption syndromes, found that he had celiac disease. I'm going to jump to some other cases of vitamin D. Again, it's getting a lot of press, which is good. People are checking levels, which is even better. But this is one girl, and this case is important because it's the only intervention that we used was vitamin D. I was consulted to a private school. This girl was an honor student, an athlete. She was African American. I was called because she was increasingly depressed, labile moods, thinking of suicide, not able to sleep. A mother who was chronically mentally ill herself refused psychotropic medications. We did vitamin D level was 8. This was a number of years ago. At that time, I only used 3,000 international units. But what you can see is that in 3 months, her mood improved. That was 33. No evidence of hypomania and depression. She did not have to leave school, and there was no other psychiatric and or biological intervention to help with an extremely difficult, very depressed individual. The important points here is vitamin D levels in African Americans are typically lower because they need more sun, and also she was lactose intolerant, was not drinking any milk, which is a major source of vitamin D for many of our kids. What I'm trying to kind of hit home here, as with the other nutrients we talked about, again, not one presentation. A 21-year-old male who was dragged out of his college dormitory naked because he was manic by the police and put in restraints, admitted to a psychiatric hospital, medicated without any improvement, and was found to have, he was also African American, very low levels of vitamin D, and with vitamin D supplementation, mood improved, and was able to return to school this year. 16-year-old had what was essentially non-existent vitamin D. So I had a non-detectable 25-hydroxy vitamin D. I've never seen that before. She was not only depressed, she was extremely flat. Some people might call her schizoid personality. It was very hard to engage, chronically depressed. But as her mood lifted with a better diet and cholesterol supplements, with vitamin D, she was able to show dramatic improvement in her mood. I'm not going to have time to go through all these cases, but we see vitamin D a lot in depression and obesity and binge eating, and again, a connection between the marijuana use and low vitamin D, as well as the low omega-3 and cholesterol. So there's something about the low fat, either absorption or metabolism, that I believe makes one prone to chronic marijuana abuse. The other routine test that we try to do on everyone in the office is the essential fatty acids. You can see here all the major omega-3 fatty acids are low, but even many of the omega-6 fatty acids. And this is a more typical pattern than we see, deficiencies in omega-3 and omega-6. The world is pretty hung up on fish oil. Large doses of fish oil are good for your heart, especially when you get the urge to swim upstream. In my world, looking at blood levels, for those that are depressed, the essential omega-6 fatty acids are often low with the omega-3 fatty acids. Essential fatty acids are critical for all aspects of neurotransmission. It takes, at least 3 months to recover the deficiencies associated with fatty acid deficiency. I throw this in here because just beginning of the research, looking at all the bipolar studies, the better studies that showing that fish oil was helpful for the depressed phase of bipolar. But some of you have seen this slide. This, I believe, is probably one of the most important studies that have come out in a number of years. It is so dramatic and so profound. It just amazes me that it did not get in the cover of Time, Newsweek, or our national news. This is looking at supplementing with omega-3 fatty acids, 81 adolescents with what we call subthreshold psychosis. These are kids that have had psychotic episodes in the past and on the verge of psychosis. They were giving 1.2 grams of omega-3 fatty acids, a very tiny dose. And if you see here, after 40 weeks, 2 out of the 41 individuals in the omega-3 group developed psychosis versus 28% in the other group. Huge differences, 5% versus 28%. The intervention was 1.2 grams of omega-3 fatty acids. Think of the public health implications. Think about what might have happened if they gave 2 or 3 grams, the lowest recommendation that I would share. This never got a lot of press and never got integrated into treatment, although there was a follow-up study last year trying to articulate how omega-3s could have this profound neuroprotective effect in delaying the transition to psychosis, particularly in the high-risk individuals we're talking about here. Omega-3 fatty acid testing is critical. Again, dietary intake does not often reveal the problem. So what I'm trying to share with you in a very hodgepodge way, but helping you try to see that some of these nutrients that we test for routinely can have profound effects on mental health. I try to see mental illness as an error in physiology, or multiple errors in physiology, and if we look at the cause, if we do these objective tests, if we look at amino acid levels, fatty acid levels, peptide levels, we might be able to find the cure. I was asked to give a webinar for a supplement company, and I used something close to this slide, and the lawyers for the company recommended I not use the word cure because they said there's no cure for mental illness. And I argued for a little bit, but they would not let me speak. if I kept the word cure because they worried about their liability. And I assure you, if we find the underlying cause, and that's the goal of our seminars coming up in Santa Fe, whether it be an abnormal test on our organic acid, the HPA marker, or a diagnosis of celiac disease. If we find the underlying cause for these profound nutritional deficiencies, we are going to be able to find remission of symptoms and essentially a cure. So we use all our tools in our toolbox. I'm going to skip these slides because I want to get to, I mentioned here, the HPA marker on the organic acid tests. I forgot I had these in here. One of the also most significant tests that I found in a psychiatric practice dealing with very severely ill patients. The HPA marker, which you'll hear more about in the conference, is a metabolite of tyrosine. It's produced from a strain of Clostridia in the GI tract. It affects dopamine metabolism, and it is the most consistent marker that I have seen with psychiatric repercussions or symptoms. This is one boy who parents have tried every medication. We've seen at OCD clinics across the country, tried multiple alternative treatments from Empower Plus to nutritional deficiencies. It wasn't until we aggressively addressed the HPA with high-dose probiotics, didn't need antibiotics, but there was a complete resolution in treatment-refractory OCD. Reynolds was a patient who had essentially schizophrenia. He was psychotic, early onset in his late teens, got addicted to marijuana, unable to make a dent in the psychosis until we were able to address the elevated Clostridia marker HPA. I'm going to need to go quickly. I have many, many more slides, but what I want to share with you is a simple test looking at levels of inflammation. CRP has been helpful as a marker of inflammation that we do in every test that walks in the office. So I apologize, I'm going to skip these. But some of the next few slides are patients that we're currently seeing in one of our group programs for binge eating. So these are men and women with binge eating problems regardless of weight. And the most consistent finding that we see is inflammatory markers, elevations of the CRP, as well as this patient had low vitamin D and zinc, and we also see the low B12 under 400. I'm going to skip these, all very, very same themes. I want to talk about magnesium for a minute, a very, very common nutritional deficiency state. Most of the time it is a nutrient that is very hard to assess because most of the magnesium is in our cells, in our bones, so serum levels are not accurate. I look at hair levels, and red blood cell levels are a little more accurate. But the symptoms that we see repeatedly, constipation, insomnia, anxiety, irritability, we see it all the time. I had a patient today walk in the office, multiple psychotropic medications, no relief. Magnesium supplementation was able to perform a real base to eliminate of these symptoms. This is my slide for magnesium cases. Essentially, everybody on the planet typically benefits from magnesium. I believe it is a just common nutritional deficiency that we can easily assess and easily treat. and really take questions. Just want to kind of share with you some closing slides. That clearly our goal is nourishing the brain, and that's the objective testing that we're talking about, that Great Plains has a wide range of tests that we're able to assess. But we also need to nurture the mind, and part of the depression book, the end is clearly that part where we look at beyond biochemistry, where a peace of mind, mind-body medicine, can also have profound implications for mental health. I like to function where everybody has at least a normal biochemical framework and can begin to be able to appreciate that without the normal biochemistry, the mental health symptoms aren't going to resolve. So we'll close for this evening. I appreciate everybody that's hung on. Again, we'll be setting up more webinars after the conference in September. We'll be setting up supervision groups for those individuals that are looking for more consultation around individual cases. I just urge you to think, what objective tests can we do? Try to understand a few of the Great Plains testing if the testing is new to you, and as you get more familiar with each test, then add another test to your practice. I appreciate your time, and hopefully if we can spread the word about looking at a different biomedical model, I believe we can truly change the face of mental health treatment, particularly for our children and those suffering adults. Again, thanks very much for your time.